All right. So I would like to start by saying thank you to the telehealth training group for inviting me here to talk today. When I prepared this presentation, I basically thought of doing a presentation that would take us from the general to the specifics. So we're going to start talking a little bit about telemedicine, general issues that we, for example, when I came here, and we'll talk more ahead about when I came here, what happened, issues that one needs to take into account and that one needs to have in mind before starting a telemedicine service. And we'll go ahead after and we'll talk about issues related specifically to psychiatry and telemedicine, and then we'll talk about my experience here in the state of Arkansas. So when I came here to Arkansas, basically, there was a brand new program that was starting, that was the telemedicine program for child psychiatry. And what basically ended up happening is that I ended up being the medical director of that program. With that, basically put me in a position where I had to learn, and there was a steep learning curve at the time, and we had to, basically start a service from zero. Although we had a lot of support because there were other initiatives here in the state, like the Angels program, where we could, where we took some help basically to set up our program. Let me ask you something. Are you guys watching the slides already?
Yes.
Okay, good. So as disclosures, I don't have any financial affiliations or interest in anything that will be discussed. I don't have any commercial interest. The only disclosure that I have is that I speak Spanglish. I have a very strong accent, so if somebody doesn't understand or ask me and I'll repeat myself. The objectives, as I said, will be to provide a general overview of telemedicine applications, guidelines in psychiatry, and then results in Arkansas. So, history. The first program that used telemedicine was in the University of Nebraska in 1950. They had a closed television circuit system where they used to do consultations. Then the term telepsychiatry was used first to describe a consultation program that was in the Massachusetts General Hospital in Boston, and they would connect to a distant site in the city, anyway, to provide consultations in psychiatry. So after that, there was like a dead period of programs or initiatives where telemedicine was used. What ended up happening after that is that in the 1990s, with the boom that we had on the internet and with technology, the capability and feasibility of using telemedicine applications became more handy. It was cheaper to use them. So people started to use them. There was a survey done in 1995, and basically 50 programs were identified in the country, here in the United States. There was another survey done in 2003, and it was found that from 23 to 27 states, there was availability of telepsychiatry to Medicaid patients. Then there was another survey in 2004, and 88 programs responded. In 2005, there were 116 programs identified. And I have to end up saying that probably the strongest telemedicine use in terms of network servicing and all of the medical specialties is probably set up in the VA system, the Veterans Health Affairs system. They use it often. They're very experienced using it. So what is telemedicine? As the word says, tele-distance medicine, medicine by distance. So it's basically the use of telecommunications. This thing has something. Let me just, it's going ahead on its own. Sorry. That'll do. There you go. So it's basically using telecommunications to provide medical information and services. Is the health delivery of consultations via use of telecommunications. In other words, is using technology to provide medical services, to provide medical information, or to access medical services. It can be telephone between two providers, faxes, video conference, robotic technology. The type of technology used are store and forward, where you basically store imaging or you store medical records. That they take pictures of whatever lesion or whatever sample they have, and they are able to do the report and send it back. The other use, which is the one that we're going to probably be talking about, is the use of the two-way interactive television, face-to-face consultation, or the Tamber machine, which provides a real-time consultation via video conference. Usually the patient with their primary provider gets direct consultations to experts in distant sites and can involve the patient directly. ITV is widely used for urban rural locations where access to care is difficult, but even in cities, in New York, or big cities where traffic and distance can be difficult in certain specialties, instead of traveling to another place, they're starting to use this type of technology. The equipment, now we have a lot of equipments out there. The only thing that I wanted to mention is that at the beginning of the use of telemedicine, the equipment used to be television equipment. As technology advanced, you started to use IP protocols, where basically you use the internet to send the data. And as our capability of sending and receiving data has become better, then we can, for example, the images that we get are clearer, that now we can see and watch people at the same time. So basically, the other issue that used to be a problem was the confidentiality of whether or not we could use the internet to do this type of interviews. With encryption services and the encryption of information, this can be done now safely, meeting HIPAA regulations. Now we can attach peripherals to the Tamber machines, like attaching peripherals to your computer, and you can listen to people's hearts. You can even take blood samples, and then the machine reads the samples and send it wherever you're located. They use it now in ambulances. I mean, the limit is the sky, as I said before. The combinations of the use of telemedicine are interactive, store and forward, audio and video still images, web to transfer data to other web applications, electronic prescriptions, as for example at this place here in the university, we're already, instead of giving prescriptions to our patients, we're now able to electronically send the prescription to the pharmacy, and that's one of the uses of telemedicine. That's kind of medicine by distance. Now patients don't have to come to the doctors to get and take the prescription to the pharmacy. By the time they get to the pharmacy, the prescription is already there and it should be ready. Wireless technology in emergency ambulances, which is already working in some programs here in this university as well. So just to summarize, the applications of telemedicine are basically from healthcare delivery, health professional education, health administration, public health, business libraries, school education. What are the benefits? And this is very much related to child psychiatry. Breaks down barrier to distance and access, improves the quality of care, because if you're able to access expertise from someone who's far away, but you're able to actually get that expertise, that improves the healthcare of that person. Providing easy access to education and may lead to decreased healthcare costs. The application, urban to rural for specialty and available care. Somebody who lives in a rural area and they may not have access to somebody whose specialty is scarce, they may be able to access that person through telemedicine. Mental health care to jail population, hospice care, consults to school nurse, home telehealth and monitoring of chronic disease, chronic heart disease. So actually that has been shown to decrease the cost in some chronic illnesses, because if you have one of these monitors at home, the person doesn't have to come to the doctor every time that they have a complication. They can actually contact the doctor over the phone and get the care that they need. Distant health teaching monitoring, what we're doing right now. Telesurgery applications for battlefield via use of robot. Teleradiology, telepathology, and most of the medical specialties now are using some form of telemedicine. What are the barriers to telemedicine? Which I can say personally, I experienced most of those. Equipment and infrastructure. So some people or some states, some areas don't have the infrastructure to access this type of services. We've been fortunate enough here in Arkansas. I would say that is one of the leading states in the country who has been kind of, let me use that word, rewiring the whole state. So they have capability to use telemedicine and this type of technology in the future. Bandwidth is a term that refers the amount of data that you're able to emit and to receive. So, and I'm clarifying that because I mentioned here that most telephones don't provide enough bandwidth. So it means that you're not able to, for example, if you don't have the proper wiring, you're not going to be able to use video conferencing or to use or to transmit certain type of data, images, MRIs, CAT scans, stuff like that, that you might not be able to do it because you don't have the proper connectivity. Licensing issues. Many states will not allow out-of-state physicians to practice. So if, for example, let's say somebody from other state wants a consultation with me, I would need to first get a license in that state. Reimbursements. There have been some initiatives, and as far as of 2006, the reports were very good that most private, some of the private insurers were already paying for telemedicine. I understand that as 2007, more than 50% of the states in the country were basically paying for telemedicine services. I don't know what the numbers are now, but this has been progressing, and the trend is that eventually these services are going to be paid. Fear of malpractice. And this is basically for, because as a physician, it's not only fear of malpractice, it's the fact that sometimes you're not seeing the patient yourself, you're not there with the patient, you may not get the whole information that you need to get. So it puts you in a vulnerable position. The acceptance of technology, and the best analogy I have for this, when I came here to Arkansas, what I've noticed is that there were some physicians in the rural areas that were kind of reluctant to use the service. And this is the best way that I can put this is like when the internet boom started. If you guys remember when we started to use credit cards to buy things over the net, most of us were like kind of, well, I'm not putting my credit card there, and I'm not receiving anything. And eventually all of us got used to it. Who doesn't buy things on Amazon or whatever? Everybody does it now. It's actually quicker than going to the store. And so this is what I think is happening, that people are getting used to it. Physicians are starting to use these services. They're becoming more comfortable. What I've experienced myself now, after 3 years, 2 years and a half, almost 3 years doing this, is that people are more comfortable now. They feel better about using this type of technology to care for their patients. Privacy issues, which as in any medical specialty, as this is a new type of delivery of healthcare, then you have to deal with new challenges. And the worry about the personalization of healthcare, as anything. You know, most people like the face-to-face, you know, attention, as has happened in other businesses. So that's something that has worried people in the past, and that continues to worry a lot of people. So what about psychiatry and telemedicine? So we're going to go and talk a little bit about some of the basic stuff that you need to have in mind when you're talking about psychiatry and telemedicine. And then after that, we'll talk about our experience here in Arkansas, okay? So what are the applications for the practice of telemedicine in psychiatry? So you can use telemedicine for diagnostic, therapeutic, and forensic purposes. Pre-hospitalization assessment, post-hospital follow-up, schedule and urgent outpatient visits, medication management, psychotherapy, consultation, emergency evaluations, and case management. Pretty much everything. Other applications, clinical supervisions, distance learning, research, and administration. So what are the standard operating procedures or clinical protocols? Appropriate staff should be available to meet patient and provider needs before, during, and after encounters. So if you're going to have a telemedicine session, somebody in the distance side should be able to follow up with the recommendations that one makes. If I say that patient needs to have this and this and this done, somebody should be able to help the patient or to enable the patient to access those recommendations. So then you're talking about staffing and local access sites, site coordinators, clinical hosts, provider site, privacy and confidentiality during session and transferring of data for clinical and administrative purposes. So you need to have a procedure to ensure the privacy and confidentiality of your patients. And you need to make sure that whomever is in the distance side, that this is not going to be like an open room like this one, and that everybody is going to be listening to whatever you're saying or the patient is saying to you. So that's something that needs to be ensured before doing telemedicine sessions. Informed consent, like in any medical encounter, you need to make sure that that happens. Regulatory authority and all requirements, liability insurance across state lines. Basically, what I would say is that one needs to make sure that whatever you do in your regular practice, it needs to happen as well in the telemedicine practice. Policies and procedures review annually. Systematic quality improvement, and this is very important to have ways of addressing your own failures or to addressing people concerns, because it allows you to improve your own programs. The most common thing used to kind of learn how you're doing in terms of providing services is surveys. So most telemedicine services use surveys to learn what was the patient experience or the provider who consulted you experience when using the service. What is the model of health service delivery? So there are two models in psychiatry. One of them is consultation, which is the one used for most programs, where you call and somebody has a question about a patient and you make a recommendation, and you tell the whomever is calling you what should follow, and then the ongoing care, which happens mostly, for example, in inpatient units or correctional services, or some, what I would say, virtual clinics. But most programs use the consultation. You should maintain professional discipline and use the clinical practice guidelines of your specialty. For us, is the APA guidelines and the ACAP guidelines. Any changes in clinical practice ensure that clinical requirements are maintained, and that providers should have the continuing education and supervision. So basically, you should have the same standards to provide clinical services that any hospital. It's virtual, but it should have the same standards. So when is appropriate to do a telehealth consult? That's determined by the referring and consulting physician. And there should be protocols for sharing client data. For example, here we have electronic medical records. One good thing is, for example, that when we get calls for certain places around the state, as we share electronic medical records, I, for example, have access these client medical records, and it's very easy. I can even write a note if I want to. So that it makes things much easier. But if that's not the case, then you should be able to have some way of sharing information with whomever is calling you, and some sort of documentation of that encounter. Cultural competency. as in any clinical practice. Cognitive testing, if you need cognitive testing, if you have patients and that's something that you require, you should have or identify a resource to do these things for you. So let's talk about video conferencing. If you're going to do, for example, an interview of a patient, and you're going to interview just the patient, it's okay if the patient is older than 21, but if there is going to be other people in there, then you need to get permission for that from the patient, unless it's a minor that needs to be supervised. But basically, there has to be, somebody has to be overseeing this, who's going to be in the room with the patient, who's going to be listening to this information, and if somebody's going to be listening to it, it should be allowed to be there, and it should be documented. Traceable record of consult at both the referring and distant site. Make a note of your encounter, like if you were seeing your patient face to face, and that should be kept somewhere. Psychotherapy. So we, for example, here we don't do psychotherapy, but it's been widely used. Telemedicine has been widely used to provide psychotherapy services. And it's the same, the standard practice guidelines for therapy shall direct psychotherapy services within the telemedicine setting. For medication management or medication recommendation, which is the most common type of use in terms of psychiatry. Telepsychiatrists work most of the time with the primary psychiatrist or with the primary care provider and give recommendations to whomever is taking care of the patient. How's my Spanglish? Is it okay? Okay, good. So the telepsychiatrists work with mid-level professionals at the local access site who write the prescriptions. And the psychiatrist directly prescribes. The methods of obtaining initial prescription and refills and reporting adverse effects should be documented as well. Administrative issues. About this, emergency protocol are a must. Like if, let's say, there is an interruption of communication, like what you were doing before starting, that you were having some issues. So there is, he knew who to call, who to contact. You need to have these things clear, because if you don't have a plan, then we're talking about patients. And in terms of a patient becomes ballistic or something like that, there should be a plan for that as well. Refer to guidelines for more detail on this. Basically, there are two main guidelines in terms of the use of telemedicine in psychiatry or telemedicine in general. One of them can be found at the American Telemedicine Association website, and the other one in terms of psychiatry and child psychiatry at the American Academy for Child and Adolescent Psychiatry practice parameters. There is a guideline which is basically saying the same thing that I'm talking about right now. So ethical considerations. You should incorporate the organizational values and ethics statements. Like if UAMS has some organizational values and ethics statements, they should be reflected on the telemedicine service. Be aware of medical and other professional discipline, code of ethics when using telemedicine. Inform the patient of their rights and responsibilities. And you do all these things when you do the informed consent. Provide patients and provide with a formal process for resolving ethical questions and issues. And eliminate any conflicts of interest to influence decisions made about, for, or with patients who receive care via telemedicine. So ensure readiness of the telehealth equipment. Make sure that the equipment is working before you start. Okay, let me jump here because I still have 20 minutes, all right? So there are some key policies that have to do with the release of information and informed consent. And I'm going over these because these are probably one of the issues that you can be born if you don't have these things in place. You should have identifying and all required patient information for a referral or consultation. JACO can come and do an audit, and if you don't have identifiers, as if you had a physical patient, a physical clinic, you'll be born too for that. A reliable process for communicating findings after consults, basically is through paper trail or your electronic medical record, ensuring privacy and confidentiality. You should have also a protocol for intake procedures and screening. So if you, how is that work? Who refers patients to you? Who takes the information down? Staff roles and responsibilities. and transmission of patient data, how that data is sent from one place to the other. Policies in use of electronic medical records, appointment scheduling, synchronizing schedules at all time, transmission of prescriptions, lab orders, progress notes, evaluation and measurement of patient outcomes, quality improvement, continuous training. And I'm just going to end this part of the presentation, summarize what are probably the most important things when we talk about these protocols, these clinical protocols. When you're going to have a telemedicine service, what are the kind of things that you need to have in place, or that are kind of a must, okay? So when you develop your clinical protocol, make sure that services are performed in an appropriate, confidential, safe, and comfortable manner, that there is a consent form, that there is availability of direct intervention in the event of client refusal to participate. In other words, you have a patient who comes to you and says, I'm suicidal, I'm going to kill myself. There should be, the distant side should have some way of coping with this situation. It shouldn't be just an empty room where the patient is just going to run off. That's what you need, a clinic coordinator at the site who's going to be able to deal with these issues. You should have protocols for emergency and non-emergency interventions. Assurance of confidentiality, secure encrypted transmission line. We shouldn't be using Skype or a messenger, you know. There was some doctors who were using this type of, you shouldn't do that because these things can be hacked. The exchange of necessary clinical information prior to intervention, okay? So if somebody is consulting you on something, the referring physician should be able to tell you what the patient is, what they're calling you, what predisposing issues or factors or whatever the patient has that they need to be in contact with you to treat this patient. There should be somebody who's going to be regularly testing the quality of the transmission prior to initiating the intervention. What Dave was doing before that was exactly that, testing that the equipment was working. Backup options in case that there is a problem. So let's say that this site doesn't work, can we go to another room, can we look for another setting or something like that. Make sure that you disconnect the call at the end of the session. And this is very common. People don't disconnect the call and they keep talking about the patient or whatever, and well. And standard documentation of the clinical event. You were going to say something?
Yeah, I have a question from one of the viewers online. Chatted in a question. This person's wondering, is it possible to utilize telepsychiatry when the physician or when the psychiatrist is in another state and the patients are in another state?
Yes.
About massive.
Yes. So this is totally doable. I'm going to give you several examples. There is a guy in Washington, D.C. who has a very lucrative family medicine practice, and he sees patients from a lot of places. But remember, you need to license yourself in all these states in order to be able to prescribe medications. On the other hand, one of the things that you need to be mindful about is that most people prefer to, when they set up for contracting with, and we're going to talk about contracting for professional services, but they prefer to do consultation just because in terms of a liability standpoint, it's safer. But it's totally doable. You can do that. You can do psychotherapy, you can prescribe medications, but you need to, for example, if you're going to do that, you need to make contact with the primary care provider, make sure that there is a need for your service, that you're not going to be like a pill bank where they're going to be contacting you and making up something so they can get medications from you and stuff like that. So contracting for professional service, I just talked about that. Identify the need. If there is a patient that really needs you, then you should be able to do that. But you need to make sure that the patient really needs you. Define the clinical expertise needed and choose to outsource. Define the service to be provided: assessment, consultation, treatment. Your expectations from the service. Identify the term of the relationship and total time needed. Ensure that your local resources can support the contract terms, filling schedule and reimbursement. in the case that you're going to contract services with somebody, you need to make sure that they're going to be able to send enough patients to you. And there are several issues that you may need to take into account: hourly rate, fixed number of hours per week, schedule out 1 year, assign expectations at both endpoints, so there are no hard feelings at the end of the year, testing the connection prior to clinical service, identify the clinical information necessary to exchange prior to intervention, make sure that you have ways to document your services, document necessary to ensure billing, and the evaluation of the contract prior to the renewal. And this is for somebody who may be out there thinking in going out of this. The digital learning curve. And this is basically the step that you may need to take in order to start a telemedicine service. So first of all, you need to look if you have enough capacity to provide this service. What we talked before about having the wiring, if you can emit and receive enough data, that you're not going to be froze for minutes and then kind of cut and stuff like that where you're seeing a patient, or that the image is not going to be gloomy or shadowy or stuff like that. So basically you need to make sure that you're going to have that type of support. Initiate non-clinical functions first, and this is for institutions or for somebody who's trying to do this type of intervention. What is better to start, like, for example, do meetings through telemedicine, do trainings, do educational activities to kind of become familiar with the service. Establish local champions, and that's very important, to name somebody who's going to know about the equipment, how to operate the equipment, if there are problems, who's going to be the person who's going to be able to kind of solve these issues. The site coordinator model. So one of the recommendations that the ATA has made is that every site should have a site coordinator who's going to be the person taking care of the equipment, making sure that it's working, and that's going to be in charge of most of the things that have to do with the telemedicine equipment. Outline and post backup procedures for malfunction. Everybody needs contact information for all potential participants. Location, and this is very important. When one is setting up this type of service, you shouldn't just set up any office. If you're providing medical services, it should be like an office, for a doctor's office. They even talk about colors, light blue as being the color for this type of setting because it doesn't reflect light a lot. So basically it shouldn't be like an office in the back of the building that nobody uses and then we're going to use this office for that. No, this is like an office. So it should be treated in that way, okay? Trial run, mock sessions, and that's basically trying it before using it, and time to adapt to the use of the technology. And it's basically allowing people to get used and to become familiar with this type of technology. So now talking about the session, preparing the client, get your paperwork, informed consent, authorizations, orientation to equipment, explain to the client, whomever is going to be using the equipment, what is this about, where do they have to look, where is the camera, where is going to be the doctor, all this type of information, because you don't want to just sit somebody down in front of a screen and, okay, sit there, somebody's going to talk to you. You need to explain to someone, whomever is going to be there, what the procedure is. Notify the client prior to the session to prevent no-shows, as you would do in a clinic. Then the session. The local access site provides administrative support and clinical support. So let's say I'm seeing somebody in Texarkana. They should have somebody able to take care of this patient in case that the patient decides that he's going to run away or something like that. They should have enough resources. If I said that the patient needs to get a prescription or something, or the patient needs to be sent to a hospital, there should be somebody there capable of taking care of these recommendations. Introduce the client to the video provider. What I just talked, have the patient introduce the patient to the provider, so there is like this introduction. The patient just is not just sitting there in front of a stranger. ensure the quality of the transmission, who should be in the room, and we talked a little bit about before this. Clinical-based decision driven by the providers. If we think, as a provider, if I think that the mother should be in, that's okay. If not, then if I think that the patient should be alone, that's okay. The originating site should have a case manager present and or available. And this is in case of that something happens that needs to be taken care of. Consider safety issues, violence, hyperactivity, agitation, and this is extremely important. I had an experience before. I was interviewing a 3-year-old. Unfortunately, we had the mother, we had a nurse, and we had a psych coordinator. If we didn't have these people, we wouldn't have been able to interview this patient because the kid was running amok all over. And it was just, it took 3 people to basically calm the kid down. So you need these things. You do need them in order to be able to use the telemedicine equipment. Now, again, this is about the room design, what we talk about, maybe using light blue. It should be an office space, like a doctor's office space. And at the end of the session, case management staff are present to hear the recommendations of the distant provider and to close out the session. So for example, here, and we talk a little bit more about that, we do have that. We have that, and we make sure that the recommendations are followed up. So, okay. The staff disconnect the call in the presence of the client. Yes, please make sure you do that. So follow up to the session, documentation, billing, and responsibility. And this is just reminders of things that people are supposed to do. Satisfaction survey. This is very important. This is what's going to tell you how you're doing in terms of the patient's experience. How do they feel when they use the service? How, what things did they like, they didn't like about the service? And you do need this because this is going to tell you how to tailor your service, how to polish it. Now, I'm going to start talking. This is the end of the last part of the presentation. And we're going to talk about what we're doing right now and what we've been doing for the last 3 years here in Arkansas regarding child psychiatry. So, and I think it's going to make more sense now because in the past when I have given these presentations, I haven't been able to give the background that I just gave. So I don't have to repeat myself as much in terms of other issues. So this is a picture of the Psychiatric Research Institute. It's been open for the last 2.5 years. This is our team. David Hendricks is the program coordinator. He's like our, what you would say, our champion in a way. He coordinates services. He makes sure that he should be making sure that connections are ready and everything is working. He shares those responsibilities with Jenny Serby, who's a program specialist, and Sherry Mayweather. We have some social workers that work in the telemedicine program, but provide another kind of connectivity services, and I'm going to talk about that later. We have 4 doctors, Jody Brown, Molly Gatright, Said Malik, and myself. All of us are board-certified child psychiatrists, and we basically are the ones who answer the call whenever somebody in the state calls about a child-related psychiatry issue. The objectives of this short presentation are to talk about what about mental health treatment in primary care settings, what is psychiatric telemedicine, how can we reach more people here in the state, and I'm going to talk a little bit about other satellites that the program has, and that are main components of the telemedicine service. So when we talk about child psychiatrists, there are not enough child psychiatrists in the country. We have a humongous shortage of child psychiatrists. It is estimated that we have 1.6 child and adolescent psychiatrists per 1,000 children, and the national overall rate is 8.7 child psychiatrists per 100,000 children. So what I'm trying to say is that the number of child psychiatrists that we have is very low compared to the number that we really need. So there is an inverse relationship between the number of child psychiatrists in an area and the percentage of youth in poverty in that same area. in 2011, there were 50 child psychiatrists registered to the state of Arkansas. Of those 50, only 31 were practicing for the whole state. So this is a map from 2001 that basically shows the concentration by color of the location of child psychiatrists in the state. This is a map that I got from 2009. It didn't change very much, but whatever you see in dark blue is where there are no child psychiatrists. So as you see, there are some psychiatrists in the Little Rock Central area, in the Fayetteville, Springdale area, and then in the West Memphis, kind of near the border with Memphis area. Other than that, we don't have a lot of child psychiatrists in the state. These are some indicators from 2009, Natural Wonders magazine from Children's Hospitals, that basically talks about the mental illness indicators in the states. And this was a survey, but still has some clinical validity. When kids were asked if they felt sad or hopeless, the rate in the state was 28% compared to 26% in the nation. Seriously considering suicide, in Arkansas was 18% compared to 38% in the country. Made a plan for suicide, 14% compared to 11%. And basically what I'm trying to show is that we had higher rates than the national average. So we have a problem with mental health here in the state, and we don't have enough child psychiatrists to provide the mental health care that we need. How many child psychiatrists we will need to do that? We would need at least 14.5 per 100,000 children in a managed, care-friendly, multidisciplinary model. We will never reach that. It'll take probably a century or something like that to basically train enough people to be able to do that. Arkansas could use at least 50 additional child psychiatrists to meet population needs. And it's just not doable. So rhetorical questions that I have for you is, if we can see all the patients who need us, what systems are in place to lead us to work with the most complex patients? And what's happening to the patients that we don't see? So, and for that, what about mental health treatment in primary care settings? Okay? So primary care and child psychiatry are two separate systems, and it has been like that for a long time. What usually happens is that it's so difficult for primary care providers, historically in the past, that used to be the case, not now, that they didn't like to deal with patients who had mental health issues, because first of all, they didn't know how to treat them, and even if they didn't know how to treat them, they didn't even know where to send them, because they didn't have anywhere to send the patients. So to that second question of what happened to those patients who we don't see, they usually don't get seen, and they stumble from place to place. These are some of the issues or the answers that we got from some of the primary care providers. This is the first time I got a consultation from a child psychiatrist. You're the first child psychiatrist who has already called me back. Frankly, I don't want to do mental health screening, because if I find a problem, I don't have anywhere to send the patient. Now, unfortunately for us, child psychiatrists and psychiatrists in general are not members of the pediatric department like many other pediatric subspecialties. So that poses another layer of complexity. There have been a lot of initiatives in the pediatrics arena in terms to try to cover the mental health needs. Pediatricians end up prescribing, not in this state, but in most of the country, end up prescribing 84% of the psychotropic medications. There have been some organized pediatrics initiatives like Bright Futures, which is still functioning and is a very good resource for to learn about mental health issues in children. The American Academy of Pediatric Mental Health Task Force and the American Academy of Pediatrics Practice Guidelines on ADHD. These have been some initiatives that have tried to cover these gaps in care for children. So how suitable is for primary care providers to provide mental health issues, mental health care? First of all, and this is across the board, families are much more comfortable to get the mental health care from primary care providers because they know them for a long time. They're not stigmatized because we still have the stigma of the shrink, the crazy, the loco. So people don't like to come to us because they're stigmatized once people know or realize that they're coming to see a psychiatrist. And it's worse in the case of a child. The primary care providers have the opportunity actually to prevention and screening, so it's easier. They know the developmental context of symptoms because they usually know the family, the in and outs of their families, especially in rural communities where the community is small. They can address psychiatric issues in primary care settings and reduce stigma in general. So the Psychiatric Telemedicine Service is a partnership between the Arkansas Department of Human Services and the University of Arkansas for Medical Sciences that is providing actually primary care physicians enhanced access to child and adolescent psychiatrists through telephone and telemedicine consultations for the last 30 months. Our goal has been to provide consultation and education about child and adolescent psychiatric related issues to primary care providers that will relieve problems with access to child psychiatry, basically. So what do Arkansas primary physicians say? I've used your call center several times. Each time your physician was very helpful and the information provided excellent. We in pediatrics are much in need of such a mental health resource, and I will continue to use your services and recommend them to colleagues. These are our surveys. Thank you so much for the service. It has been very helpful to our practice. Great and timely help, polite and courteous, will help me continue to give my patients the best care possible. Thank you for helping seasoned pediatricians take better care of my patients. So basically people are really enjoying this service and taking the advantage of using this service. What is our service? We provide 24/7 access to a board-certified or eligible child psychiatrist for all primary care providers. If you make a call right now, if you call our number, you should be able to get in contact with a child psychiatrist in less than 15 minutes. This service also offers basically diagnostic and psychopharmacologic consultation. So this is the sketch of our program. So we have on your left we have the telephonic consultations and psychiatric evaluations, and that entails psychopharmacologic consultations, televideo, psychiatric evaluation, disposition, referral consultations, or treatment planning advice. This is done through telephonic consultations through a call center. Basically, people call our call center here at the university, and then whatever is needed is set up from there. If they get in contact with a physician and it's decided that the patient needs to be evaluated face-to-face, then an appointment is scheduled through the Tamper machine or our face-to-face equipment. If the issue can be resolved over the phone, if it's a medication question or something that can be talked over the phone, then it's done that way. We have the discharge, aftercare follow-up, or diagnostic unit, which is basically a 90 days case support. We basically provide 90 days of follow-up care to patients who are discharged from the inpatient unit that we have here at UAMS. So what the telemedicine service does, we have some social workers that once the patient is discharged, they make sure that the patient gets to the appointment, that they have the appointment, that they can find a doctor. If they don't have medication or if they having problems with the school, the social worker basically makes sure that all these issues are worked. They contact the families weekly for 3 months. And then we have educational activities. We have monthly grand rounds, and we have 3-year round tables. We have developed some guidelines or some documents basically tailored towards primary care providers to help them deal with issues like depression, infant mental health issues, anxiety disorders, substance abuse, bipolar disorder, and other topics. And these topics, these guidelines, if I may call it that way, are available in our website, and they're very friendly. Okay, we talk about that. Access. So this is our numbers, and the access to our we basically get in contact or get calls from AHACs, physician offices, emergency departments, community mental health centers. This is our practice guidelines, already talked about that. This is about our unit, the child diagnostic unit, which basically accommodates children as young as 2 years old up to 12 years old. And I'm talking about this because even though it's not specifically related to what telemedicine tells itself, I think it's important for people in the state to know that because we do follow those patients afterwards, that there is this service available. Now, we're going to talk a little bit of what we had for the patients, the type of things that happened during the first year. First of all, if you see, for example, from 2010, we had 36 calls in total. Then in 2011, we had 86 calls. And as of this year, we had already 45 calls, which is much more than what we had at the 6 months mark a year ago. So this year, we're probably going to have 100 and something calls. So every year, we're getting more and more calls. And that's something that we learned that because we consulted with people in other states, and they've told us that it was going to take a couple of years to for the service to pick up. These were the diagnoses that we had from 2010 to 2011, and I basically divided them in what were the most common and least common diagnoses because I thought it may provide some information. But what I think is important is that is a little bit of everything. The most common diagnosis on that first year was ADHD and mood disorders. Then we have the reason for consult. The most common reason for consult was medication advice. Aggression was the second one, and suicidality was the third one. And one thing that I think is important to mention is that we set up our service. When I was talking of how to set up the service, we thought that we should do a consultation service. Why? Because if we had an ongoing kind of clinic type of service, we would have become flooded with patients, and we wouldn't have been able to help more people than what we're helping right now. This is in terms of our disposition. What I can say is that most of our patients got treatment recommendations and psychiatric evaluations. We refer some patients to the ER that were suicidal or violent and that there was no way that we could help them. We actually avoided for at least 5 patients, if I'm not mistaken, to go to an ER. And I think it's important to mention that because every ER visit is like $16,000. So if you can equate that in terms of saving money and probably making healthcare for everyone cheaper, that's one of the reasons why having this service is probably is worth. Now, the information for the program is available on our website, the Arkansas chapter of the American Academy of Pediatrics, and AFMC is also providing literature and contact information. I'm going to leave some time for questions if somebody has any questions.
Okay, let's open it up to the questions to anybody on interactive video if those people want to go first. And I've got a few questions from the people online. And if you're still online, please chat in your question. There's an Ask a Live Question button above the video stream box, so if you missed that, take your questions. So anybody in the interactive video world?
Don't be shy.
Yeah, don't be shy. This is your chance. While people are getting their nerve up, I'll ask a question. We had kind of a comment, I guess. A provider from Louisiana says, in his state, in Louisiana, there must be a licensed provider in the room when doing telepsych. Is that this? I mean, is that the case in Arkansas or other states? I mean, a licensed provider, I guess, on the originating end with the patient.
Yes. This is what every state has different regulations. The regulations in terms of how to provide telemedicine care by state can be found on the website of the American Telemedicine Association. And they have divided in terms of each state what is required for having this type of encounters. In terms of Arkansas, as I mentioned at the beginning, we require for our program, I'm not saying that this is a state mandate requirement, but in our program, we do only take calls from physicians or physician offices. And when we do face-to-face consultations, we require a nurse or a physician to be present in the office. And that is because if we have a recommendation to make, we need somebody to be able to follow them up. So when Medicaid established the service thinking about increasing the access to child psychiatry services for primary care providers. So that's the issue or the reason for why the service is only open for use for primary care providers in this state.
Okay. Let's see. You mentioned, I mean, I guess working with the pediatricians around the state.
Mm-hmm.
They've been receptive. I mean, how about the other general practitioners? I mean, have they been receptive as well?
Yes, I think that first encounter is the key. What I have found is that I've traveled around the state personally because this is a state program, so I've been fortunate enough to kind of being able to go and present the program in several parts and several hospitals and mental health centers and stuff like that. What does work the best is to establish relationships with people, because once that people see your face and know who you are, they feel less uncomfortable in calling, basically on calling you back. But if there is no at least that little scent of human contact, then I think it takes more time. It takes a little bit more of time. Even in terms of return of calls, we've been more successful when we've been there physically than by sending vouchers or emails or stuff like that.
One question from Louisiana again, and then we can wrap it up. What type of equipment is necessary for the physicians to have their office? I mean, I guess, equipment in their office, this person's saying who provides it. Have you used Skype for consultations?
No. So again, so Skype is a totally different technology. It's a wireless technology. Skype can become encrypted, but it doesn't meet HIPAA regulations as far as I understand. The equipment can be found again at the American Telemedicine Association. They have the websites and they have all the brands and all the most common equipments, and the prices go from from $1,500 to $10,000. It depends on what you want and how you want it. But there are a lot of options, and these equipments are becoming cheaper by the day because technology is advancing and becoming more accessible to everyone. So an equipment that used to cost, let's say, and I can say this, $5,000 2 years ago is costing now $1,500. So it depends on what are your requirements, because it's different to just have, for us it's just a timbre machine. It's just the video conference. For somebody who's doing radiology or something else, they need different equipment and different stuff. So that's where the variation goes.